guide together. We'll do you can change this as your time too. So we can go over the last two lectures and kind of mind dump right now. And then we can talk about how it relates to previous topics as well. So on purpose, the last two lectures were light-ish, right? And more content was stuffed into the first two exams. That way you could focus on the final exam. I'm not sure if you like that or not, all right? Or you'd like to have a whole bunch of extra work for the study for the next 4 days. So that's why I'm trying to think about what would work best for you guys too. Okay? So yeah, that's why today's lecture was half strength. All right. So what else? That's an ED pun. Anyways, we have eyes and ears. You want to dump and also male. Do you just want to do a mind dump, closed note about what you know about male GU? So what do you know about male GU? So I kind of filled in some of the blanks there. Erectile dysfunction, right? What are the causes, right? What is defined as? What are the causes, right? Unable to intercourse. Stress is a cause, right? So psychogenic, you have stress there. Decreased blood flow, which is SNS, right? Hypertension. You got decreased blood flow from diabetes. You got decreased blood flow from ASCVD. What else? Alcohol can also vasoconstrict. Alcohol can also disrupt the brain stuff. Smoking can work on testosterone directly, but it's also going to vasoconstrict, right? ETH smoking is always attached to everything. You got decreased testosterone. What decreased testosterone? Aging. That's a big one, right? You can even add in like prostatectomy, right? They took out the prostate. That's going to cause ED as well, right? Anything else got causes? So when you learned these processes, you separate them into causes, right? Or like general stuff. What's some general things about it, like common, non-common, slow, not slow, right? And then causes, right? So risk factors is technically what it is. And then we talk about symptoms and diagnostic tests, right? Got symptoms and diagnostic tests. You got treatment and then complications. I mean, erectile dysfunction doesn't have complications. I mean, maybe you can't have kids, but it's not like as serious as something like death or acute urinary retention, right? Or pyelonephritis. You don't get that from ED. It's more of a psychological. It can be psychological, but also anatomical. I don't know. Right? So these are kind of the basic things you want to know for most of these processes. And with meds, for instance, same kind of thing. Like, what are examples of the meds? How does it work, right? So we talk about meds, right? So you want to talk about, how it works, right? Which is the mechanism of action, right? Then we have, what else do I know about meds? You know what are side effects, right? You want to know examples too. Yep, let's put that up top. To try to find some suffixes or prefixes or things that sound like what it should be, right? And then last thing is nursing implications, right? That aren't the other ones, right? Like the side effect is hypotension, or let's say the side effect is, I don't know, I'm trying to think of a good one. Flushing, but you're not there's your measure not going to observe for flushing. It's like, okay, that's redundant. You want to make your study guides nice and lean, right? So you can get the right information. But there's something specific like bisphosphonates, right? Yes, it causes esophagitis. So how do I fix that? Take 2 glasses of water. What else do I do? Just sit up, right? So that's something specific that I didn't get out of the side effects, right? And that's it for like medications, and then RX, and then there might be surgical options for ED. Yes, there are surgical, and usually like non-pharmacological are going to be first, right? And those are kind of your nursing interventions, right? Those are your interventions you can recommend, right? Don't smoke, don't drink, don't do this, don't do that, right? Make sure you're relaxed, make sure you have this and that, and then we can then go on to surgical options, right? So surgical. Oops. Surgery, right? What's the surgery you do for ED? It's an implantable pump, right? Pump. So that's what we do. And what does the implantable pump do? It's you got to pump it up, right? That's basically all of. There's really not very many complications. It works, right? And then as far as going back over to like non-pharmacological, what's some nurse interventions or tips and tricks, things you recommend, devices. What is it? You got zinc, right? So supplement, right? What else? Got exercise. Exercise is always the right answer, but in this case, it definitely works. What else? Got sleep. How much? 8 to 10. Or was it 6 to 8? I think it was, right? 6 to 8. Right. What else? What else do you recommend? Huh? The ring. Right? So we got it's got devices, right? So we got the penis pump, right? Swedish penis pump. So we use that and it cause, right? So it's going to cause a cold member. Okay. What else? The ring. The ring, right? That's the ring that does that, right? So muscle mass, that's exercise, right? Muscle mass. Testosterone can help with that, right? Also, we can check their testosterone, right? That kind of goes with the diagnostic tests over here. Testosterone, right? So less than 250 is our line in the sand, right? That means that's not good. In your 20s, you're like in the 1,000, right? 1,000, 1,200. Less than 250 in your 20s is a problem, right? So that's something we can look at. Tumescence, psychogenic versus organic. So which one's which? So psychogenic has what? Does it break the stamps or not break the stamps? Breaks the stamps, right? Or that Rigiscan, whatever it is. It breaks the Rigiscan meter, right? Whereas anatomical or structural problem, right? Or testosterone problem, we're going to have what? No break, right? So it's not going to, you can put pictures in there, it's fine. Drop some pictures in to understand what that means. All right, signs and symptoms, right? They just self-report it. That's all they got to do. They self-report it. There's that little survey that they can do, right? Low numbers are good. Low numbers equal ED. Anything else? The definition is unable to intercourse, so that's also right here. All right, anything else ED symptom-wise? They could have, as far as causes, we kind of mentioned there's some anatomical issues, right? The pepperoni disease. Decreased blood flow is psychogenic, could be anatomical. All right, they got Peyronie's. Anything else you mind up in those categories? All right, so real quick, let's do farm, and then we'll look at our notes. All right, so farm, we got non-farm about ED meds, all right? So you got PD5 inhibitors, avoid nitrates and alpha blockers, right? Because alpha blockers are going to vasodilate, such as the BPH ones. What are some alpha blockers for BPH? Those are the ones that have like Zosyn, right? Zosyn and Osin, the one I screwed up, right? Terazosin, tamsulosin. Tamsulosin was specific, so it's not really going to have as much of the hypotension, but the Zosyn ones, I didn't confuse you already, the Zosyn ones were the ones that were non-specific. So it's difficult to say specific, right? It's easier to say specific, so the one that has S in it is the more specific one, right? And then PD5 inhibitors, what else is important about them? So they have what suffix? Affill, because they affill it up, right? What else? What else about PD5 inhibitors? They're the most common prescribed meds for EDs. That's why we spend more time with them. So remember, for medications, you want to know some general stuff, examples. So we got Affill, how it works, the PD5 inhibitor, right? Side effects. They got vasodilation, right? So side effects. That's why we're going to avoid nitrates, right? All right. So what are some side effects of vasodilation? Some flushing, congestion, right? So everything's vasodilated, you get those symptoms. And then some rare things that are not as common, we could get the blue vision, right? And that goes the blue pill. And we're going to avoid nitrates for the first most common side effects of vasodilation, right? And then also, what's another good teaching strategy? You would tell them they're taking any ED med for that matter. But since PD5 inhibitors are the most common, you got it kind of goes hand in hand. Avoid nitrates and avoid what? Yeah, but what other teaching strategy? It causes fifth member gangrene.
Oh, very.
Yeah. So you're gonna tell them, make sure you avoid a priapism. Okay, I will.
Call if your erection lasts
Yeah.
3 hours. Like 3 hours a week.
Greater than 3, definitely 4. Right? Because that equals priapism, right? And we can take a detour there, but we do have some other meds. And then priapism. So you injected it where? 10 and 2. Definitely not where? Not 12 and 6, right? You can put a little rationale there, right? At 6, what's at 6 o'clock? Urethra. 12 o'clock is the nerve, right? Other things you do for priapism, right? You have to aspirate out all the blood that got in there. Injection of phentolamine, which constricts the tissue. Right? Not vasodilators such as prostaglandins, alprostadil, which is this guy right here, right? Prostaglandin, or other meds. Alprostadil, right? And that was the Muse, urethral injection. Right? And then we had intracavernosal injections was our other. Same tips and tricks. We're going to make sure we're injecting at what? 10 and 2, right? And we had alprostadil, and we had some other ones on there too. All right, anything else about priapism? All right, so we got it's caused, but we put down causes, right? Cause, ED meds, obviously, but what else to kind of link to the past? I never played that game yet. All right, and then, sickle cell disease. All right, there could be some anatomical issues like trauma could do it too. But yeah, big ones that we connect to this subject, this class is SCD and ED meds, right? And what else? Anything else about priapism? All right, so look at your notes. So we've dumped our brain, we've formed synapses where synapses were never one before. Now we're gonna kind of pick what we've missed. And now you're not gonna miss those things in the test. Oh yeah, it was that one, right? So look at the slides, like was it 8 slides, whatever. What are we missing that you think is important? Anything else? Did we get it all? 100%? Good. Can't forget the hidden penis. So med side effects. I thought I put a list somewhere. I might not have dropped it in. By the way, meds that could cause this, and that's usually causing decreased blood flow, or it might be causing decreased testosterone in some fashion. Psych meds can cause ED. I wonder where I put it at. I mean, it's all right. Anything else? So causes, decreased perfusion. What else? Smoking. We mentioned that. Low testosterone, good. So it's going to have low T, right? Can cause, it's not really a symptom, but it can be down here. So you usually get the mood swings. Fatigue, mood swings. What else? Weight gain for low T, right? All right, so we talked about the level of testosterone. The name of that score was International Index IIEF. I can test you on like which one is it, international index or is it the prostate one? It's not. All right. So REM sleep and testosterone increase tumescence. So that's, I didn't kind of stress that, but testosterone definitely causes tumescence, but also REM sleep does. That's on that graph there in the bottom middle. That's why it has those diurnal variations, or has those variations based on REM sleep also. All right, what else? Anything else? Non-pharmacologically, missing anything there? Skeletal muscle, sleep, zinc, body fat. We put body fat. It's kind of with exercise, right? Maybe that's what I was thinking. 12, anyways, 10-ish%. What else? Got the prosthesis down there for mechanical. It's a kind of non-pharmacological implantable pump prosthesis. Requires surgery, but in the meantime, we have the penis pump that we can use. Okay. What else? We got PD5 inhibitors, priapism management. Anything on that slide that we forgot? All right, so it's, yes, there's ischemic and non-ischemic, but the one we're going to focus on is the SCD, which is ischemic. And the ED med is going to hurt, right? It's erect and it hurts. All right, you got the glands that is non-erect, so like priapism, right? Erect shaft, deflated glands, deflated. Okay. What else? Talk about the injection, how to take out the blood, right? Some side effects there. And then we can talk about some more medications, right? Some more medications. We got the alprostadil. I forgot about papaverin, and phentolamine. So papaverin. Okay. That's your meds for ED, right? And those ones are given intracavernosal. So the teaching we mentioned was to make sure that we do good technique or alcohol swab. Make sure we inject it. I think it's good within 10 to 20 minutes, right? And then we got to wear condom for that, right? For both of these. Especially the prostaglandin one, right? But also these intracavernosal, we got to wear condom because why? They're exposed to blood now. And how do you, what transmits via blood? Which is a good question from the final. HIV transmits via blood, right? So put at the top here what we connected to the final, right? So you got blood versus blood transmission, mucus transmission, I guess you would say, transmission, saliva secretions, comparing the two, right? So what's blood again? HIV, which HEPs? B and C, right? This was HEP A and E. Technically, secretions are droplets. You could say TB, but really TB is sputum, right? It's TB, right? So that's why we wear what? 5 reverse, not reverse ISO, but negative ISO. All right, going back down. So anything else ED wise? I think we got it all, right? All right, close your notes. Prostate cancer. Let's dump our brain for prostate cancer. Prostate hyperplasia, BPH. You can go backwards too. You can still go all the way to testicular cancer, meet in the middle. Literally in the middle. Right? But anyways, let's do, we got ED, let's do prostate. So BPH, again, you kind of want to know your causes, you want to know your signs, symptoms, diagnostic tests. Right? Treatment, and we got non-pharm, and we've got some non-pharm in there we can recommend, right? So teaching down here. So dump your brain. What are some causes of BPH? Got low testosterone. All right. What else? Got low blood flow, right? Which is increased SNS. Right. So it's the same thing as above. Hypertension. What else? Diabetes, right? And anything else? Age, right? That's kind of on the low T part. All right, symptoms. You got wise and fun, right? What are symptoms there? What is it? So we get signs and symptoms of like complications, right? So this is where you get the retention. That's later, but let's go back up to wise. What is wise? Weak. Intermittent stream, right? Or what is it? It's, what is it? Straining. So incontinence, or what does it stand for? So that's where they're stopping and going, right? Or is S stop and go? Straining. E is emptying, right? That's where you get the tenesmus, or what do they call it? Overflow incontinence, right? And then funny. What is funny? Frequency, right? They're going to frequently. What else? Urgency. That kind of plays with the I at the end. Nocturia. And incontinence. So you got two incontinences. This one is which? Stress? Stress is usually like coughing. Coughing or weak. So we'll look at that. All right, the complications. Then that if the urine is staying behind, then we can have a UTI, right? And the UTI can be in the bladder, right? Which is which one? Which is what? That can be in the kidney, which is what? Nephritis, right? Bladder is what? Cystitis. And what are UTI symptoms? You got pain, right? There's dysuria. They got SIRS, which is fever, right? White count. You got positive leukoesterase and nitrates. Nitrates. All right? So those are signs. You have that, and then CVA pain is high-low only. That'd be our another one here. It's got UTI, and we got some hydronephrosis. Right? That's where you're having it's backing up, it backs all the way up to the kidneys. If it doesn't cause the kidneys to get infected, it can cause the kidneys to get compressed with urine, and then you get an AKI, right? Doesn't really have much symptoms besides, it's usually one side that's affected. Either way, you can have acute kidney injury. Hydronephrosis is going to cause too many symptoms. It's going to be they're going to have the symptoms of AKI, which you'll learn about next semester. Symptoms of AKI. Yes, they're going to be oliguric, anuric even, but with post-renal syndrome like this, when you're blocking the outflow, you'd have to block both kidneys, right? Because you have two outputs, so it's more difficult. They're not going to feel good, right? But they may have like some non-specific symptoms. UTIs would be much more specific. Okay. So kidney injury. All right, diagnostic tests. You got all the symptoms, right? Diagnostic tests, or some DX for them. You can do a DRE, right? So what is a good DRE? Finger breaths, I should say. Right? And it should be non-what? Well, I should say normal, right? And with the DRE and them be greater than 2 finger breaths, right? Should they have induration? No, that induration would equal cancer, right? All right, you got smooth, right? That's a normal finding, just greater than 2 finger breaths basically is DRE, right? So you got smooth, right? And they got a little cleft in there, a little butt crack. Okay, so the butt within the butt. Anything else DRE wise? Lubed finger is good idea. Because you're a kind nurse. right? 360. You're only assessing the anterior surface, or should I say posterior prostate. Anterior can grow cancer. Can grow cancer, but BPH will be big. So it's not gonna, if it's big, it's BPH usually. It could be prostate cancer, so that means you have to do another diagnostic test, which is what? A PSA, right? So PSA looks like what? Greater than how much is concerning? 4, right? And we got all this business about free and not free, right? Bound, right? Or unbound. So what is it with BPH versus prostate cancer, right? So prostate cancer has more bound or more free? Right? Whereas BPH has less bound, more free. You can organize that into a table and then be done with it, right? To see what it looks like. All right, and then what else? So that's kind of 25%ish, right? PSA greater than 4 and less than 25%, or sorry, more than 25%. I'm saying here's a total one. How much is bound versus unbound, right? So percent, 25%. All right, and then what else? And we'll look at our notes to see which one is less than or greater than 25%. And then another diagnostic tests. We could put the MRI in there. It's not wrong. We could do the NP MRI, little tiny MRI, as an alternative. You're going in for a GRE, you might as well say, well, you know what, I think I'll get the MRI, right? It's like a menu. All right, treatment, how do you fix it? So this is actually supposed to be with prostate cancer. RX down here. That's like the last step. But yeah, watchful waiting is the treatment. Right? And then when can you no longer watchfully wait? Complications, right? But kind of the first step before that, you can say until interference, right? With life, right? It's causing a lot of problems, and we can hook them up with some meds, but it's causing complications. Meds might work for like 3 months or so, but really we're gonna have to progress to surgery, right? Down here, some surgical options. We got what's the number one surgical option? TURP. All right, but going back up here, RX, we got meds, all right? This is if it interferes with life. Just to reiterate, surgery, complications of BOO, right? Bladder outlet obstruction. And then meds. What are some meds for prostate? Which ones? Finasteride, we're going to stop DHT, right? Anti-DHT, they're also called 5-alpha reductase inhibitors. They stop DHT production, which increases growth. Good. Masks PSA. All right? And then what are some examples? So we got examples, right? They all sound like steroid. Right? They all end in steroid, right?
I have a question about the two different methods. So do we have to know the time period it takes for them to?
Just that it's slow. I mean, because for the watchful waiting, they take like 3-ish months, right? 2 to 3 months to work for both of these ones. So meds interferes with life, take 2 to 3 months to work. All right, so we got steroid. What are some examples? Finasteride, right? Right, and you can highlight them so you can kind of see how it lines up, right? You get fancy. There's not enough time to get fancy sometimes. All right. All right, and then any other meds? Blocking the alpha receptors, right? Because remember we talked about BPH is because of SNS, right? It causes low T, low blood flow, increased SNS at alpha receptors. alpha 1 receptors. So we'll link that down here. And it makes sense for medications are going to block alpha 1 blockers, right? And that's where I steered you wrong with the Zosyn and the Sosin, right? Right, so like Terazosin, right? Or what am I thinking of? And then we got side effects of both of these guys, right? If we're blocking the SNS, we're gonna get hypotension or hypertension. You get hypotension, right? And that means we're definitely gonna avoid with what ED med? PD5 inhibitors are afils, right? Any other meds? Maybe. All right, SIP surgery. So what surgery can we do? We got TURP. We got like a radical prostatectomy. We can use lasers. And then we just use minimally invasive stuff. Right? They do small, like for those that won't tolerate above, right? We have little tuna, tubed, and some other ones, right? And then CBI is needed for our TURP and prostatectomy, right? So also the thing that you get TURP syndrome is called. They get overload with irrigant. But CBI, what's some CBI stuff? You still got your CBI right there? So it should be pink lemonade, right? When do you increase or decrease flow into the bladder? So you increase the flow when it's what? Bloody or not bloody? Bloody. All right, so bloody equals what? Increased flow, right? Blood clots, not pink lemonade, right? Well, I guess that's not correct because it could be less than pink lemonade. But if it's too dilute, then you would do what? You would decrease the flow or even clamp the CBI until it returns back to a pink lemonade. It starts getting darker, then we're going to go ahead and unclamp it and see how it does. It's a game, you're going back and forth. There's no perfect science to it. All right, so that's CBI. Teaching for this kind of back to the non-pharmacological, and we're watchful waiting. And I misspoke with that one. We're going to make sure we give what? Antimuscarinics or muscarinics. We're going to stop the acetylcholine from binding there, right? So I think I put down there, avoid anticholinergics on the slide, so I got to correct that. But either way, cholinergics or anticholinergics, we're going to avoid meds like cholinergics, because cholinergics bind there, and they're also going to promote prostate growth, right? And what else? Double void, don't drink at night, sit while peeing, anything else? Avoid caffeine, right? ETOH. It's gonna make you pee more. What else? All right, so let's look at our notes. Let's look at VPH. See what we're missing.
Alpha 1 blockers, the Zosyn is specific.
So Zosyn, which one's specific? Specific. This one, right? Okay. I said it like 3 times backwards, of course. Right. And what are some examples? What are some examples of the specific ones? Tamsulosin, the other one starts with an S, right? What is it? Samsulosin? Something like that? The nice thing about Google, it'll sometimes correct it, but... All right, and what else? Anything else we're missing from our list here? Let's scroll back up. So if it causes inflammation, right? That's going to be like obesity, ASCVD also does it too. Smoking. Anything else? We got causes, symptoms. Did we get the symptoms right? What kind of incontinence was it? Urge incontinence. Has the U in it, so that makes sense. But the U does not stand for urge incontinence, so it might throw you off. But it sounds like urgency, urge incontinence. Diagnostic test, what's the 25%? Was it less than or greater than? So greater than 25% what? Free. All right, NPR, MRI, anything else? Treatment? Yeah, IPSS is the kind of survey we can do, right? Anything else we're missing? Any other teaching or any other side effects we're missing with meds? I feel like there's another med down here. So it's anti-acetylcholine, right? So we're going to stop the acetylcholine that's binding there, and that's our muscarinic antagonists. Muscarinic, right? That's our, they end in odine, which is nice, right? Right, and finally we got our little PD5 inhibitors also work down there. All right. Anything else with this one on surgery wise? Teaching? So I'm required to add some STATA questions to the test. So put some STATA probably on that guy. All right. Teaching you do for BPH. All right, is this working or is this boring? It's like, why you guys?
It's boring.
Okay, it's boring. Good to be honest. All right, do you want to keep going? Cancer. All right, so let's do prostate cancer. So close your notes and let's dump our brain about prostate cancer. What do you know about prostate cancer? Family, right? Age can do it. So testosterone is related to it, right? Anything else? So good. So as far as risk factors, so high dairy, right? High calcium can put you at risk for prostate cancer. I think it was obesity in there, I think. It's usually in most cancers, so if I was trying to bet in Vegas, I'd probably put obesity. All right, symptoms. It's usually asymptomatic until it's big enough. It's so slow cancer, right? So it's going to cause BPH-like symptoms, right? So which are what? You're funny and you're wise and funny. And that can lead to BOO and AUR, acute urinary retention, which is your UTIs. And what else? Fancy word called hydronephrosis, right? But it can cause pain as it starts getting bigger and bigger, compressing nearby structures. Back pain, if it's metastasized, good. So metastasis, but that's kind of a complication. All right, so metastasis, and where does it like to go? Bone, spine. That's BLT with, what is it? Kosher pickle and mayonnaise and mustard, right? So that's our pickle. prostate pickle. All right. Any other symptoms? Diagnostic test, we have PSA greater than 4, and we just decided it was a percent free, less than 25%, right? Because there'd be more bound PSA. All right, so then DRE, is it recommended? No, right? Because it can be anterior. Can be anterior. All right, so get an MRI. That's what's recommended. I mean, it may be recommended if you're high risk because you have a brother, uncle, dad, right? That may have had it. Any other diagnostic tests? Not really. About treatment, how do you fix it? Prostate cancer. There's also watchful waiting as well, right? Because it's aggressive. It is a slow cancer.
Under risk factors, wasn't it also tall white guys?
Tall white guys.
Okay.
So localized, and we have diffuse, I guess you could say. All right, it's metastasized. That's where we have to give them what? Our security system. We have to give them ADT and chemo, right? Localized, we can do what? Radiation, right? And surgery. We can do a prostatectomy. Take out the piece that's missing, or that's cancerous, prostatectomy. Okay? And prostatectomy, I don't think we put it up here, but what's the complication of prostatectomy? Cause ED and impotence, right? And then down here, we had our reverse ejaculation, right? It's a cool party trick. What else? Radiation, we got some, we can deposit radioactive seeds, right? What's that called? Starts with a B. Brachytherapy, right? And we got some teaching, right?
And those are 2 weeks, and condom for 2 months.
You gotta be specific with your teaching. It's like, hey, we can have free uncondomed sex for 2 weeks, and then I have to wear a condom. So it's a condom the whole time. Right? People interpret things in crazy ways, right? Like a open heart patient, we told him, just take it easy, and then he took it easy. He was on bed rest for 4 weeks, and he got a stage 4 pressure ulcer. So they told me to take it easy. So okay, you never know the mental capacity of your patients. Right? The average reading style is like 6th grade, right? Anyways, we got what else? Surgery, radiation, ADT. That's where you deprive what? You deprive them of androgens, right? Androgen deprivation. So we're stopping some enzymes here. We're stopping a few of those testosterone enzymes, like the androgen receptors. And we have the conversion of DHEA conversion. That's like the most popular one. And we had a few other ones in there. So we got some gonadotropin blockers.
Is ADT the chemical castration?
Yeah. All right, and we got chemotherapy, we got our docetaxel, that's our taxane, right? And taxanes cause what side effects? Okay. All right, so let's look at our notes. What do we miss? So risk factors is teaching, diagnostic tests, RX. Where did we put that? Was it tall white guys? Alright, what else we got? Anything else we're missing? Signs and symptoms wise, it's asymptomatic, right? Until it's big enough. And then it'll start causing localized pain. If it's metastasized, it'll definitely go to the spine. Not BPH or STI is a good one. It could get painless bleeding, right? As it erodes into the urethra, start causing bleeding, or erodes into the bladder, causing bleeding there. We got all our favorite cancer symptoms, right? Right. We forgot biopsies. So if you got a PSA, you got an MRI that's positive, then it's time to do biopsy times 2. Anything else we're missing? We got radiation, we got surgery, ablative therapy. Abiraterone's the one I hear the most as far as this kind. Yeah, you said urinalysis? That's for like retention symptoms, right? Up here. Where am I at? Over there, down there. DHE conversion. That's our abiraterone. I think medical castration. Enzalutamide. Enzalutamide. All right, so anything else we're missing treatment-wise? All right, last one, testicular cancer. What do we got for testicular cancer? So let's close your notes. What are some, everyone? Tall white guys, you know, risk factors. Also, going to be family history as well, right? Jeez, there it is. Family history. Treatment. Undecided testing, good. What else? So it's usually some risk factors, but like it's usually young, slow growing. There is that 5% where it is fast, but usually 95% of the time it's a slow growth tumor. Good. So they have, and those guys usually have undecided testes too. So Klinefelters, I think it was. So symptoms also asymptomatic. Usually, it's usually asymptomatic. It's painless, right? Painless bump, any variety of bump, right? It could be smooth, bumpy, indurated, whatever, right? So some teaching, right? We're gonna do some teaching for what? A TSE. How often? Monthly, right? Post shower, right? And looking for different shape, consistency, all those good things. And then if it does grow big enough, right? If it's big enough, then it can start causing pain. Kick and balls pain. Some of us know what that feels like, but. And then it can metastasize, the complication, right? And where does it like to metastasize to? It can go to the bones, but usually it's going to be going to very vascular areas, right? Lung, brain, bones. All right, what about diagnostic tests? What can we see? Oh, we might have it. That's our AFP positive, right? You can do ultrasound, they can do the light test, light illumination test, whatever it's called. Transillumination test. Usually that's probably be done at home. That's something they can do after the shower. Why do you have a flashlight in the shower? Why is the lights off?
Monthly shower time.
It's shower time. Is that Rectix? What's yeah. It's just a precursor test. It's for you to get seen if it's like, oh, there's something different here. They can do an ultrasound to see if it's just like a hydrocele or something non-cancerous, or it could be something that you get to look at, right? And if we want to treat it, how do we treat it? With chemo, we can do chemo. Before we do chemo, we can do cryopreservation. Cryopreserver. But then we can do surgery, or I can do a what? Orchiectomy. Take out the orchid. All right. Anything else? Let's look at our notes and make some more connections. Hmm? Because remember, those germ cells can produce anything. They could produce uterine tissue. Cool. So bleomycin does what? Makes blue lungs, right? Etoposide. We don't really give you side effects for that one, but cisplatin, we give you side effects. Otonephrotoxic, right? It's also very, very nausea vomiting like, right? How do you fix nausea vomiting? Give antiemetics like the what's it called? That starts with an A. I just had it, I forgot it. But dexamethasone, steroids are really good for this. So that's your exam, or your about 20-ish questions on these ones, right? On eyes, ears, and what's it called? Male GU. Okay. Do the same thing for sensory neural. I don't want to spend too much time doing it, but what else do you want to talk about as far as the final is concerned?
What are you going to test the most
On this content is the most. There's 20 to 25 questions for these ones. Or like 10 each. It depends how it lays out.
Well, that leaves 50 for the rest of us.
So 50 questions for the other ones. So probably 25 apiece. Right, for exam 1, exam 2. Right. So do you want to go over those kinds very generically?
Practice questions would be
Is it math heavy? It's going to be like 10, 15%, whatever is there. I haven't done the exact number. It's not med heavy. To me, 50% sounds med heavy to you, I know. But. And SATAs, I'll try to do the least amount of SATAs that don't require, someone else to notice. So I'll probably do like 10%. We'll see. So if there's 75 questions, what is 10% of 75? Like 8-ish questions, right? So we'll do like 8 to 10 SATAs, somewhere in there. All right. What else do I do? Or are you tired and done? All right. I can tell you what it was last year, but I don't know what it was. I have to update it from last year. So last year there was 9 eyes, 5 ears, and 12 male, which is like 25-ish, somewhere in there. And then hematology, musculoskeletal, and oncology. hematology. So you got 10 hematology, 9 musculoskeletal, and 9 oncology, which is like 30, but I'll probably bring that down a little bit. And then sepsis was 7. So it was a little bit different layout last year. Hepatobiliary was 8 questions. GI, the tubes, right? That was 10 questions. EKG was 10. IV push was 8. But it's also including like other medications you would get at IV push, right? That's like IV push medication we gave today. What IV push medication did we give today? IV push, that was probably more last week. Eyes, ears. What IV push meds do we give for eyes and ears? Ones that are ototoxic, right? Also, we can give it for like Meniere's disease, right? We give IV push meds. So did you want to go over eyes and ears, or?
Yeah.
So, yes, so that's kind of the basic layout. It's going to be a little bit of everything. Okay. So for IV push meds for like cardiac, right? What are some cardiac IV push meds? Adenosine. What is adenosine for? What rhythm? SVT. And you know what SVT looks like? So recognize SVT and recognize that this medication is for it. Don't pick the slow rhythm, right? And vice versa. Like, what's the side effect of digoxin on the monitor? Side effect on the monitor. They could have the ST scooping, but also there could be a slow rate or a fast rate if they're on digoxin. It should be slow, but when would you give digoxin? When it's a slow rate or a fast rate? It's fast, right? So you get to dig then. What if you gave too much dig? Then what's it gonna have? Yellow halos, right? So if they're seeing yellow halos, then we have to consider probably dig. We can have halos with some of our eyes and ear stuff, right? Or eyes specifically. But what else? How would you fix that? You give Digibind, right? And then what other IV push meds do you give for cardiac? Mm-hmm. Epi, good. When you give IV push epi, you give it 24 times this year, right? So when do you give epi? When it's lethal, all right? So it's lethal, you give epi. All of them, you give epi, right? Not all of them do you do cardioversion, right? So you have synchronized and unsynchronized cardioversion, right? So I'll kind of take some notes up here. So you got synchronized, unsynchronized, right? And we got epi for all lethal. So you guarantee there'll be some lethal rhythms on there, right? Because that's a safety net. Make sure you know your stuff. It's like, oh, that, you can't just like, oh, they're fine. No, that's a problem, right? That's something that should get addressed, right? So for all lethal, what else did we mention? We talked about IV push for, our eyes stuff and for other things, and then cardiac, right? That's how we got to this topic. We talked about ABCD meds, right? All the ABCD meds we can give IV push. We can give A, which is what? Amiodarone / little a, just for one specific disease process. That was our adenosine, right? B was what? Beta blockers. That's specific. Those are man-babes, right? We can give those. So the rhythms in front of you, what are you going to assess before you give the metoprolol? A, that it's fast enough to give it, right? The PR interval is important because the PR interval tells you that you have too much what? Too much metoprolol on board, and you might have an AV what? AV block, right? And then C is what? Calcium blockers. Which calcium blockers? Your Rapmil and your Diltiazem, right? And then D sounds like Diltiazem, but D is our digoxin, right? And like reversals, all right? So we got Digibind, and what else can we reverse? Adenosine only goes away in 12 seconds, so you can't reverse it. So, right? You can't take that back, but you can take back a beta blocker and a calcium blocker with what? With glucagon, right? And then Digibind specifically for binding Digi, right? And we're going synchronized. We talked about on the lethal rhythm path, right? So lethal rhythms, you got synchronized, unsynchronized. So all of the lethal rhythms, you're going to do either synchronized or unsynchronized. You got to choose which one's which. But all lethal rhythms are doing two things: epi and what else? CPR. Now the distinction is like which one do you shock and not shock, or sorry, you're going to shock them, but which one are you going to do synchronized or unsynchronized? The brush put down here. Which do you not shock? Right? And which do you do unsynchronized? Basically no pulse, right? no pulse, and not PEA, asystole, right? Because if you have a pulse, what do? Synchronized, right? So which rhythms have a pulse that you would do synchronized cardioversion for? Would you do it for sinus bradycardia? No, it's for fast rhythms, right? These are fast, so synchronized is for fast, right? Rhythms with pulse, right? Unsynchronized could be fast, no pulse, or it could be, what's the one that looks like this? Defibrillating and no pulse, not atrial fibrillating. Atrial fibrillation usually going to be synchronized cardioversion is too fast. Your question?
Oh, it's also if the blood pressure is less than 90 because you can't
Good.
get mad. So it's like a beat.
Fast rhythm with pulse and good. So
Beat track with a pulse but less than 90.
yeah, because all our ABCD meds did what?
They will
They can lower your blood pressure, except for DIG a little bit. All right, DIG will raise your blood pressure a little tiny, just a little skosh. So it's not appropriate to give ABCD meds if the blood pressure is what? Is low. It's not going to be the right. And also heart rate wise, PR interval wise, and QT wise with some QT prolonging drugs. Amiodarone itself can do it. Amiodarone, psych meds, and what are some antibiotics that do it? Fluoroquinolones. All right, what else do we have? So, like, who gets for IV push? We can give some IV push for nausea, right? Nausea, vomiting, for chemo, right? Especially like our platinum agents, right? And some other ones. So, what are some nausea, vomiting for chemo? Dexamethasone. And the one, aprepitant, is that the one? And then you got some ondansetron, and you got your metoclopramide. Those are all IV push meds. You look back at IV push, like, oh, I know that med. I know that med too. So those are all meds we discussed with chemo. What else? So what's the risk for IV push? What's the ultimate side effect? All right, too fast, speed shock. And EKGs, we talked about EKGs. And what else in EKGs? We talked about halos, talked about if you have like a surge response, what EKG finding would you expect? Something fast, right? When you have a abnormal structure to your heart, you might have AFib, or you might have SVT, you might have VTAC, you might have torsades, right? But it can be a fast rhythm if you have, a tachycardia, or a heart rate greater than 90 to 100, right? So then, what other questions? What other topic do you want to talk about? Paced rhythms, right? So knowing knowing failure to pace, failure to capture, right? If you're anemic, what EKG would you expect? Huh? If you're anemic. Something fast, right? So SNS is firing off, right? And what else? So, like H's and T's. What are H's and T's associated with? That's with your lethal rhythms, right? And what's in hematology can cause an H or a T, specifically the T. Sickle cell disease, good, cause thrombus, right? Because that's one of the reasons for an exchange transfusion when they have a stroke or they have a heart blockage from an MI, from a thrombosis, right? And then also in hematology, like leukemias have this complication that can cause EKG changes. Potassium, what raises potassium in hematology? Tumor lysis syndrome, right? So what does hyperkalemia look like? It has peak T waves, and then it just pulls out into bradycardia, into asystole PEA. All right, so what else? So do you want to keep going, or you're good? All right, so GI-wise, GI, you had hiatal hernia, GERD, etc. So you can look at sleeping positions, right? What's a good sleep position for GERD or hiatal hernia or the PUD? It's going to be upright or supine? It's upright, right? And sit on the left side or right side? You want your left side up, right? You want to sit on your, I'm thinking of right, left. No, you want to be on your left side, sorry. Left side down.
I have a question about
Yeah.
that. I remember you said pillows are not good, but did you mention something about there being a specific pillow for that?
So a wedge is ideal, right? If they got like 5 pillows, I'm not gonna fault them, right?
The wedge is under the mattress, or
Ideally under the mattress, yeah. And they can buy pillows nowadays. What's that?
can you still use it under you?
You can, yeah, but I mean, they have these like the picture of that specific GERD pillow. That's what they can wear that. They can use that. All right, what else? Like identifying a hernia, like what hernia type is it? So what are the hernia types? You got inguinal, femoral, which just means it's lower, umbilical hernia, ventral hernia, which is kind of, umbilical is a little different. Yeah, ventral, umbilical. What causes ventral hernias to happen? It's usually a surgery of some sort. And then we have, what else? Incisional hernia, which is kind of ventral almost. They kind of go hand in hand, and it can descend to the testes. But also the other one is hiatal hernia. Is also a hernia of some sort, right? And then diverticulosis versus diverticulitis, which one bleeds? Diverticulosis bleeds, right? Diverticulitis can cause fistula and cause peritonitis, right? What else? As far as like labs, we mentioned like gastric cancer, liver cancer, colon cancer, testicular cancer. There's this, right? CEA is common with the GI cancers, but AFP kind of overlaps a little bit, right? AFP was with our which one? Our liver cancer, right? What else? Which, as far as cancers are concerned, you have colon cancer, which GI process causes colon cancer. I heard it. Yeah, it's ulcerative colitis, right? Crohn's technically could, but ulcerative colitis is all up in the colon, right? Cause colon cancer. And about Crohn's disease, what's a complication of Crohn's disease? You get small bowel obstruction. What else? You get fistulas. What else? Because it goes through the whole wall and causes peritonitis. What else? Anemia. Very good. So because it affects what part of the colon? The distal ileum, right? What gets absorbed in the distal ileum with the help of intrinsic factor is B12. So they're going to be B12 deficient, right? That's a commonality between them. All right, what else? We have like teaching for esophageal cancer, right? What's some good teaching? Alarm symptoms. Good. So they have dysphagia symptoms. These are part of your alarm symptoms. And then we have, what am I looking? They're going to make sure they get their EGD, and also they can become Barrett's esophagus and esophageal cancer can develop from that, right? And then talking about prep for EGD and colonoscopy. How do you prep for an EGD? For EGD, your MPO, you have to have a consent for both, right? EGD and colonoscopy, and really there's really not much prep, right? Just MPO. But the colonoscopy, you do have to prep. And what's a good prep look like? Go lightly mag citrate, right? And then what should it look like? It should be straw or clear, right? And then the other scope in the esophagus. What's the other scope you can scope with besides EGD? ERCP, good. And what's a complication of ERCP? It's pancreatitis, right? So pancreatitis can develop. And what's a lab finding for pancreatitis or symptom of pancreatitis? You have a lipase that's elevated, right? So your lipase is elevated, low calcium if it's a severe pancreatitis, good. And then if it's causing gallbladder blockage or it's due to gallbladder stone, it might back up and cause liver involvement and gallbladder involvement, right? And what labs would be elevated then? GGT, alk phos, and then we're involved in the liver, so what else would be elevated? Some AST, ALT, right? And what else? Pancreas. So pancreatic symptoms, your point to where it should be? Should be the right left side. mid epigastrum or left, usually that's where the pancreas sits, right? Where do I have that over here? Yeah, so the hot spot for disease processes. So we have, where's your gallbladder at? That's on the right upper quadrant. And what's that called? When it's painful on inspiration. That's Murphy's sign, right? What else? Got going back into the organs, right? So we have, what are some complications of cirrhosis? So portal hypertension, which kind of progresses to all the other complications, such as varices, which can be a GI bleed, right? Hepatic encephalopathy, which has what symptoms? It's going to be ALOC, right? Is definitely there. What else? Hysterexis, right? That's just a flapping hand tremor, right? It's kind of unique to it. It's other disease processes can also have it, but hysterexis and ALOC, and what lab value is elevated is ammonia, right? And then we talked about portal hypertension causing GI bleed, right? And what are your GI bleed symptoms? So upper is hematemesis, which can lead to hematochezia. You have coffee ground emesis, and then the last one is bright red blood per rectum, or also known as hematochezia, right? And then how do you tell there's something else that can give you black tarry stools? What is that? It's iron supplementation. So what's the difference? One causes constipation, one causes diarrhea. Which one causes diarrhea? The GI bleed does, right? Because vampires have diarrhea. What else? We have talked about hepatic encephalopathy, and then what else can you do if someone has portal hypertension and low albumin production? What's going to also going to develop? They can develop ascites, right? So how do you know someone has ascites? The belly's big, right? There's a fluid wave test you can do, right? And you can eat. How do you fix that? You give paracentesis, right? You do a large volume paracentesis, and then you take out all that volume, so you got to replace what? Albumin. Okay. And what else? So, as far as teaching for, it's kind of too late with cirrhosis, but for teaching for like gallbladder and teaching for pancreas, how do you prevent that? Is lose weight, and what else? Low fat, no alcohol is a big precursor to those two, right? Also precursor to hepatocellular carcinoma. And then as far as we're talking about that, besides this virus causing cirrhosis, it can also cause carcinoma. And cirrhosis itself can cause carcinoma. What are the viruses that usually end up developing into cirrhosis? Hep B and C usually become chronic, right? And then that means we mentioned they are transmitted via how? Blood, right? It can be mucus too, right? But it's primarily blood transmission. If you get a needle stick injury, what do you have to do? You have to let it bleed, wash it, and then get medications to prevent it, right? From proliferating. And where's I going with that? We're talking about cholecystitis, teaching, cirrhosis labs. So cirrhosis labs, you expect the ammonia to be high for hepatic encephalopathy. What else would you expect cirrhosis-wise? I think you have SBP, right? That's a peritonitis, right? So albumin probably be low, right? What about the sodium? What do you expect the sodium to be? Be low as well, right? You have all this absorption of free water, right? The aldosterone's kicking in, and the AEDH is kicking in. So we got to stop both of them. So what medications can we give? We can give a medication for the ADH, but we got two medications for the sodium in the water. That's another good IV push question, right? Furosemide, good. And what else do we give diuretic-wise? Spironolactone, right? So spironolactone and furosemide are given for ascites, right? What else? We have, as far as blood spread, what else spreads by blood? HIV, right? And how long does it take to get HIV? It's about 12-ish years, right? So it takes a while, right? So what's some risky things that could cause HIV? Could be partners, but what else? Drug use, IV drug use can lead to it. It can also be Hep C as well, right? There's a little overlap there. And if we're talking about stool transmission, what transmits via the stool? Hep A and E, right? Also, what else for like MDROs? C. diff, especially. VRE can, because they cause UTIs. It can spread that way, right? Not washing our hands. Technically, MRSA is like third place. Usually MRSA causes skin and pneumonia, but third place can be UTIs. So washing hands is always going to be the right answer. When is foaming in, foaming out not going to be the right answer? With C. diff, right? And as far as like isolations, so what isolations do you use for MRSA? It depends, right? Little asterisk. If it's in the lungs, you use droplet. But if it's just not lungs, then it's what? Contact, right? And then as far as C. diff infections, what do you use? Enhanced contact, right? Which means just do not foam in, foam out. You have to use soap, right? And also bleach is going to kill everything. So use bleach though if they have C. diff for sure. And what else? So isolation wise, we already tested you on Acinetobacter isolation. What other isolation do you use for non-MDROs? For not an infectious source? So neutropenic is one, and there's another one. Tuberculosis is not an MDRO, but it requires a lot of effort, but it's not an infectious. It's like more like to avoid chemical exposure. For chemo, good. So how do you avoid chemo? So you have to double up everything, and you wear an N95 in that case, right? So we wear N95 for TB, we wear N95 for chemo, right? And then that's what handling chemo. And then back in neutropenia precautions, we do that if they have. We already tested you on, and we just that already on, to prevent an infection when they have a low white count, right? All right, what else? We got hematology is kind of going in that direction with chemotherapy, right? So we talked about already kind of the last test to create. Last semester we used, or last time we did this, chemo was part of exam 3. That's why I moved it into, or part of the finals. That's why I moved it into exam 2. So you have time to process it and marinate on it. But definitely probably another cell cycle. Like where does this work in the cell cycle? As far as probably another chemo complication. What else? As far as teaching, all right. As far as we didn't test too much on the chemo, not the chemo side effect man, but like just chemo in general, like alopecia teaching versus mouth sores teaching versus what else? Nausea and vomiting. We already mentioned IV push meds we can give, right, for that. And back to hematology. What else there? So, what causes pica? That's iron deficiency, right? What causes neuropathies? B12. How do you fix iron deficiency anemia? Diet is always the right answer, but also iron deficiency, you can also give them IV form, right? PO form. You can have the side effect of what? Tarry stools and some constipation associated with it. And what's life-threatening? Bleeding, I should say. What's life-threatening? Any kind of GI bleed is life-threatening, right? So did I say that? I don't know if I phrased that right, but you can bleed when what's low? Your platelets are low. RBCs are low, you're going to get what symptoms? Anemia symptoms, which is pallor, SNS symptoms, pale conjunctiva and such. But low platelets, you're going to have what symptoms? You have skin bleeding, you can have hole bleeding, but the hole that matters the most is the GI hole, right? So that's a medical emergency. And as far as like Hodgkin's, what does that look like? Is it painful or painless? Painless what? Painless mass. Usually the neck, it could be the armpit, it could be any lymph node, technically, but most commonly in the upper body. And you have a painless mobile mass, right? And that could cause, it can spread. Which one's the worst one? It's non-Hodgkin's, right? Whereas your regular, and then it can spread and crowd the bone marrow, and then everything gets low. But what causes high white blood cells? Not lymphomas, but what? Leukemias, right? Leukemias cause high white blood cells, except for CML. They all cause everything. White blood cells always high, and everything else is always low. Meaning what? What else is low? RBCs and platelets, except for which leukemia? CML does not has a elevated platelet. It's the only one that's different. And then as far as teaching for low platelets and hemophilia for that matter, what are you going to teach them? No contact sports. What's an example of contact sport? Like wrestling, football, something that contacts, right? Baseball, soccer, these are all things that are contacting. It's like baseball's boring. He's gone already. Anyways, it's going to cause it's going to hit you and it's going to cause bleeding, which we want to avoid, right? Is swimming a good activity? Yes, that's great activity. Is foosball a good activity? Yes. What is foosball? That's table soccer, right? Soccer's not good. Table soccer's okay. Is ping pong okay? Yes, some people hit those ping pongs pretty fast, but you know, that's a better alternative than soccer, or football. Okay. All right, and then also teaching for bleeding. What else do you teach? So we got a soft toothbrush. We got a straight razor or electric razor. Electric razor. All right. We talked about symptoms already. Who has B symptoms? It's a trick question. They all do. Leukemia and lymphomas do, but it got attached to lymphomas. But what are B symptoms? Those are your night sweats, right? Because your body's working overtime making all those non-functional white blood cells. All right, talked about hemophilia teaching. We talked about that. And what else? As far as teaching for SCD or treatment of SCD, how do you fix someone with sickle cell disease? What's your priority? Is pain, right? Preventing hypoxia. So you got the O2 stats more than what? More than 92 at least, right? And then what else? You're gonna hydrate them, right? You're gonna vasodilate them if you can. Warm them up if they're not febrile. And then musculoskeletal. So we talked about bisphosphonates and teaching. What do you teach with them? Those are your take with water, and also do it GERD style. It's like Ghana style, right? You could do GERD style, which is what? Upright for like 30 minutes or so. Those are dronates. So alendronate, zoledronate, right? And zoledronate is also used for what disease process? For what complication of diseases? Leukemias. Tumor lysis syndrome, yeah, you can use. Back it up. Tumor lysis syndrome, you don't use these calcium drugs. When do you use calcium drugs? It's also an oncological emergency, but it's not tumor lysis syndrome, because tumor lysis syndrome has what? Has plaque, right? And the C is the only one that's low. So again, this zoledronate is going to make their calcium even lower, right? So, but what other oncological emergency would you give zoledronate and denosumab for? For what? Hypercalcemia. And which white blood cell disorder causes hypercalcemia? All right, BLT with a kosher pickle and multiple myeloma, mayonnaise and mustard, right? So multiple myeloma can metastasize. So can prostate cancer. So can, what is T testicular or thyroid? I think it's thyroid, isn't it?
Yeah,
Thyroid / testicular. So yeah, so it's going to be, those things can go to the bone and they can cause the bone to break down. And then we have to give what meds again? Zoledronate and denosumab, right? In those cases, you're giving an IV. They don't have to be sit upright, right? But PO meds, PO bisphosphonates, you have to sit upright and drink water, right? And we talked about osteoporosis, or we talked about exercise or contact sports, but we want to contact exercise for what musculoskeletal disorder? For osteoporosis, right? So osteoporosis, we do weight-bearing exercise. So what's an example of weight-bearing exercise? Running, right? Balance. So if you're taking classes at the gym, what class you're going to take? Zumba is good for balance, right? Also doing like river dance is good. Doing things that are putting a lot of stress on the joints is good, right? So OA versus RA, which one do you want to put stress on the joints on? Neither one, really. You want to lose weight, right? So that's why you recommend what? Non-weight bearing exercises, right? Such as swimming, right? Doing the elliptical is a good thing. It's non-weight bearing, right? What else? We got dips and pips, like which ones affect which, right? OA versus RA. We got total joint replacement, like the hip. What's a good post-op hip and what's a bad post-op hip look like? A good post-op hip is aligned. Should one leg be shorter than the other? No. Should they be adducted? No. Should they be more than 90 degrees? No. Should they use an anal ligament device? No, right? So that's a squatty potty.
I thought they're not supposed to use them?
Squatty potty is going to make them more than 90 degrees, right? For hip. All right. So what else? As far as like gout teaching, how do you teach for gout? Exercise is fine. What else? Don't smoke, don't alcohol, don't what? Don't aspirin. No purines, so low purines, right? So urine and uric acid purines right? And we give what's medication for severe gout attack and also for what other, this was an actual true story, tumor-like syndrome has a complication of pluck, and the U in pluck is what, BUN or uric acid? Uric acid. So it's the treatment for acute gout, it's the treatment for tumor-like syndrome. It costs about $12,000. It's uricase, right? So yes, we give those, but teaching wise, to avoid that hospital bill, what can we give? What can we teach? Avoid high fructose corn syrup and also avoid, organ meats, beer, brewer's yeast, all those things. Okay. What else? We talked about RA symptoms, right, versus OA symptoms, and how to fix OA. How do you fix OA? What medication would you give? You just straight up NSAIDs, right? That's the best we got. We can give some intra-articular, steroids, right? What else? The hyaluronan is kind of fading out, but the steroids is definitely there. Scoliosis symptoms. What does scoliosis look like? That's a good SATA question, so I don't think I tested you on that yet. So they got uneven shoulders, got uneven everything, right? And they got an S, or they got kyphosis or lordosis. Which one do they have? We got an S shape, right? All right, so we did oncology, musculoskeletal. Did we miss anything? Yeah, we skipped over eyes and ears. All right. So that was a quick study session, and that was 30 minutes of studying, right? Just to review all the things. So this was like, oh shoot, I don't know OA versus RA. That's what we should go back and look at, right? All right, what else? Are you done? You saturated? Mm-hmm. Yes.